Hello, everyone. My name is Sangtae Kim. Nice meeting you. I am working for the Seoul National University as a professor for Department of Periodontology. Uh, Thank you for joining us for the Dentium Live Surgery. Today, I'm here as a moderator and a commentator. I will explain each procedure of the live surgery and make some comment for each procedure. Before we start, let me briefly introduce myself and Dr. Seung-Gun Lee. This is me, moderator, Professor Song-taek Kim, working for the Seoul National University. I specialize the perio and proso in Yonsei University and Buffalo, and working as a professor in Department of Perio. This is the surgeon, operator, who's going to perform the live surgery today, Dr. Seung-Gun Lee. He is graduate from Seoul National University and got the PhD degree in Seoul National University. He is now a director of the Korean Academy of Implant Dentistry and a member of Korean Academy of Oromaxillofacial Implantology, and also director of the private practice. So let me briefly review the case preview. Today's subject is immediate implant placement and simultaneous buccal horizontal bone grafting. This is patient information. 60-year male patient present to the clinic with a cheek complaint for the implant placement and the GBR. He has planned to move abroad after the implant surgery. That's why we cannot use the non-resorbable membrane today. Usually, the Dr. Lee's preference, I have heard, the titanium mesh, but in this case, we cannot remove the titanium mesh later. Therefore, he's going to choose the resorbable membrane for today's live surgery. As a past dental history, he had the implant and the GBR 3 years ago, 27 and 46, and the tooth number 47. And the present illness, there's no specific present illness. This is the clinical photo and the panoramic radiographic view. The number 32 and the 41, 42, this is going to be extracted due to the loss of the pretty much of the bone and also has some mobility. So we're gonna place the implant immediately, and simultaneously we're gonna do the buccal horizontal bone grafting. As a graft material of choice, we're gonna choose the osteon xenograft, which is xenografting material, and also osteon 3 collagen is synthetic collagenated bone graft, and also going to use the GBR kit. So something like, the membrane pin, and also we're going to use the membrane, collagen membrane too. This is a radiographic view, and also CBCT, cross-sectional view, and the coronal view. If you see number 31 area, the red box and green box and blue box, you can see the number 31 area before extraction of the tooth. So we have to guess after the extraction whether there is going to be enough bone for placing implant or not. Probably we're gonna plan probably number diameter 3.6 millimeter of implant will be placed. Then probably the upper part, coronal part of the implant thread could be exposed a little bit. Therefore, we are planning the horizontal bone graft on that side. If you see the number 32 area is the edentulous area, we don't know when the tooth was extracted, but anyway, you can see the horizontal resolved ridge. Therefore, this area is not good for the placing implant. If you see carefully the red box, we're gonna magnify the red box. So right hand side, you can see the arrow, the two. Probably we can guess that is the submental artery or sublingual artery, some branch. Therefore, the middle of the mandible is not good place for placing long implant. So we have to be very careful. I'm gonna explain later more after the live surgery. So number 41 area, you can see the ridge is not enough for the placing implant without bone graft. So as I mentioned, after placing implant, there will be some dehiscence defect on the buccal side. Therefore, probably we're gonna have to place the bone graft and the membrane. As I mentioned, we cannot use the non-visible membrane for this case. Therefore, we're gonna use the collagen membrane, visible membrane, collagen membrane 2 application. You can see the right-hand side. So for stabilizing the graft and membrane, we can use the membrane pin in the GBR kit in the Dentium. And also we're gonna finish with the primary intention healing with the suture method. This is before starting the live surgery, I would like to show the similar cases. The case 1, GBR and implantation with titanium mesh. This is surgeon's, Dr. Lee's preference. So after elevating the flap, you can see pretty much of the defect on the buccal side. Therefore, trim the titanium mesh and fixed with the stabilized with the with the pin. And so apply the bone graft material and the cover with the collagen membrane. It is controversial. Some people say, some researchers say that we have to apply the collagen membrane to minimize the exposure of the non-resorbable membrane. In other literature says we don't have to apply. There's no benefit applying the collagenous membrane. So Dr. Lee's preference is applying the titanium mesh and covering with the collagen membrane. So totally for 3 layers of membrane was used. So for stabilizing the membrane pin was used at post-op. And for the second stage implant surgery, you can see there's pretty much of the bone, newly made bone, and some particle is shown on the top of the implant, but still we can guess that still the healing is going on. So after this post-op radiograph and final prosthesis. The similar case 2, the implantation with the GBR surgery using GBR abutment. After extraction, because of there's pretty much of the large defect on adjacent to the number 32. So we didn't place the implant immediately after extraction. We waited 3 months after extraction and placed the implant. Still, on the number 32 area, there is large defect. So we had to decide which method we're gonna apply for the bone graft. So as I mentioned, titanium mesh was used and bone graft was applied and covered by the collagenous membrane. After 5 months after the surgery, you can see the left-hand side. There's you can see the shining membrane surface, which means there's no exposure of the area, which means we got pretty much of the new bone on this side. So, healing abutment and customized abutment applied in the final prosthesis. So now we're gonna go to the Dr. Lee's clinic. So as I mentioned, we're gonna extract the crown and bridge on the anterior tooth area on the mandible. Already this crown and bridge work has mobility. That's why we decide to extract the teeth. It's important to minimize the trauma on the buccal plate. So buccal plate, once the buccal plate was gone, it's very difficult to make it again, as all we know. Therefore, during the extraction procedure, we have to be very careful to minimize trauma on the buccal plate. So teeth were extracted. And evaluating the socket, extraction socket, if there is some granulation tissue, it will be better to remove it. But anyway, we're gonna open the flap, so we're gonna see it later after elevating flap. For the crestal incision, number 15C blade is being used. For GBR cases like this, we don't consider too much about the papilla on the midge of the canine. Therefore, the incision included the papilla on the buccal side and made some modified vertical incision because after grafting, we have to do some advanced flap advancement. Therefore, we need releasing incision and vertical incision to elevate the flap to cover for the primary intention of the healing on the grafted side. On the ringer side also, using the number 15C blade, making the circular incision, clavicular incision. Sometimes for placing single implant without severe defect, we consider a papilla preserving incision design. But for this case, we have to do pretty much of the grafting. In that case, we don't need to consider the papilla preserving incision. Instead, we have to consider tension-free flap design after grafting. For elevating flap, sometimes the orban knife, the interproximal knife, could be used as a parasite elevator. And sometimes it can be used for the secondary second incision. It's not blade, however, we can cut a little bit, some tissue, soft tissue inside. Also the linger side. Dr. Lee only included the incision design on the linger side up to probably the first premolar area. Maybe he's going to make some flap advancement to linger side later. So elevating flap including the papilla area, full thickness flap. So orban knife could be a useful tool for the elevating flap, like this. And using the periosteal elevator, some scraping motion. It looks like using two instruments, one on left hand side, right hand side, using periosteal elevator and another periosteal elevator for the scraping motion, the elevating full thickness flap to expose the bone. There should not be any remnant of the soft tissue on the bone for the bone grafting procedure. Yeah, exposed all the alveolar bone, and we can evaluate the contour of the alveolar bone, and we can expect where the defect is going to be after placing of implant. Fortunately, there is not much of the bone loss adjacent to the mesial of canine. So then we don't have to consider the GTR procedure for the area. However, we have to thoroughly remove the plaque or the calculus on the tooth surface, some kind of root planning procedure. On one hand, he's having the tissue forceps, tissue plier. On the other hand, probably he will have blade or periosteal elevator. I don't really like to use the blade on the lingual side. We already know the upper part of the lingual side, there's not really important anatomic structure. However, once we cut some important anatomic structure, there's going to be a lot of bleeding. So instead of using blade, I prefer using the periosteal door instrument like a periosteal elevator, but Dr. Lee is using the number 15C blade to making the advanced flap, releasing incision on the lingual side. I'm going to explain about the lingual side later, the anatomic structure after the lecture. The purpose of the releasing incision, as all we know, for making the primary closure after grafting. It's evaluating whether the flap is enough for covering all the augmented area. I think it's enough. At the same time, we have to consider the releasing incision on the buccal side to enhance for the enhancement of the flap. It's a surgeon's preference. Usually, I prefer doing the releasing incision after grafting because once we made the releasing incision lingual or the buccal side, there is going to be more bleeding. So therefore, my preference is grafting first and the releasing incision later before finishing the grafting procedure. That's Dr. Lee's preference. The another releasing incision, we have to be very careful the location of the mental lobe. Mental lobe usually located between the first premolar and second premolar area, but the location is very different for every single patient. So we have to evaluate the location of the mental nerve, mental foramen. Probably he already did. The anterior area, there's not really important anatomic structure, but we have to be very careful on the premolar area. Mental nerve is go from the mental foramen and innervated, like this. So check on the buccal side of the gingiva. We have to minimize the risk of the numbness. For this case, I think it's okay. So evaluating whether the flap is enough for covering all the grafted material. Releasing incision up to the muscle layer, then we can make a more advancement of flap. However, there will be, some more swelling and ecchymosis. Tension-free, making sure the tension-free. Tension-free flap design and the primary closure is more important for the non-resorbable membrane. However, still, when we are using the collagenous membrane, resorbable membrane, still we have to get very careful to make primary intention healing. Otherwise, the graft material is going to be dissipated, and the graft material and membrane would not be not secured in position, which means the failure of the graft. So flap design, tension-free flap design, and primary closure is, I think, one of the most important things we have to remember for the grafting procedure. So in the next procedure is bony site preparation. For the anterior mandibular anterior tooth replacing the implant, we have to place the implant as close as possible to the adjacent tooth. Otherwise, the final procedure looks very weird. So making the as close as possible, but should not, touch the tooth surface. We have to use the direct extension for the ideal implant position and the angulation. So placing one side, placing the one drill on one side and the bony preparation on the other side, then we can make the parallel position, parallel each other of the implant, two implant. Is it very important to placing two implant parallel to minimize the error of the prosthetic procedure. And also we have to consider to minimize the size of the defect on the buccal side. Anyway, there are going to be some defect on the buccal side, as we already saw in the radiographic image. However, we have to minimize the amount of the buccal bone defect. Next step of drilling. We can control, we can change the RPM. However, in this case, the most compact bone on the lower anterior area, we have to use maybe the full drilling speed, RPM. $1,500, $2,000. Mandibular anterior tooth area, usually the diameter 30.6 would be selected. For maxillary anterior tooth area, for sometimes diameter 4 millimeter could be chosen. But however, the lower anterior area, there's not enough bone width. Or this will be the final or the before final drill. Checking the parallel each other and also minimizing the bony defect on the buccal side. This is a procedure for the cortical perforation, decortication. So important. It's controversial. Some people say it's really important. Some researchers say it's not. We don't really have to. But I always do the cortical perforation for this kind of cases. So I'm gonna explain later more about it. My preference is using the number 2 round bar or carbide bar, but Dr. Lee is using the Lindemann drill for cortical perforation. It's important for the exposing the cancellous bone. Then we can expect some fusion of newly formed bone and pristine bone after the healing with this cortical perforation procedure. And scraping with the looks like terrace elevator. CM9 terrace elevator. Not much of the bleeding, luckily. Sometimes if there's a lot of bleeding, it's very difficult to do the surgery. Placing superline implant with the double thread design and 3.6 diameter and 7 millimeter length, 10 millimeter length. Using hand wrench for the motor. The location of the platform of the implant, we have to consider the finer prosthesis control and the margin. So it's recommended to place the implant maybe 3 millimeter under the finer margin of the final restoration. For lower anterior cases, I usually placing implant. In some cases like this, we place the implant for a 0.5 millimeter of the under the cortical bone level. Luckily, we didn't have any, buccal defect after bony site preparation and placing implant. And evaluating whether the lingual side implant was placed enoughly. Once the fracture thread is exposed, lingual or buccal side, there will be more chance of the peri-implantitis after several years later. There's no buccal bone defect after placing implant, but still we have to do the bone graft. I guess we have to, because if there is a thin layer of the buccal bone, there is going to be some bone loss on the buccal side, and eventually will be end up with the exposure of the implant surface on the buccal side, which means there's more risk of peri-implantitis and difficulty for the maintenance procedure. So not too deep, but not too shallow. So it's three-dimensional ideal position. Implant has to be placed on that position. If possible, as one recommendation is two platform of the two implant would be better to the same level. Otherwise, the patient would have some difficulty in some tooth brushing. So my recommendation is placing the same level of the platform of the two implant for the maintenance care. Better maintenance care. You can see through the implant drill through the thin layer of the buccal bone. Therefore, we have to consider the buccal bone graft. Thin layer, probably less than 1 millimeter, will be gone after several months. Therefore, we have to overbuild the bone graft on the buccal side to prevent exposure of the implant thread on buccal side. Placing maybe same size, 3.6 millimeter diameter and 10 millimeter length of the implant. If you see mesial and distal side of this implant, it's not in the same level. The bone level on the number 33 mesial area is higher than the other side. Then where do we have to place in how deep we have to place the implant? Considering the adjacent to the mesial side of the number 33, we have to place implant higher. But as I mentioned, it will be better to place the implant at the same level for several purposes. So always we have to think, not too deep, not too shallow. Based on my experience, if the implant was placed, when the implant was placed too deep, a little bit deep, it's not going to make any problem. However, if implant is placed very shallow, there will be more chance of the exposure of the implant surface. and more chance of peri-implantitis. So my preference is placing implant about 1 millimeter below the bone level for the safety. And checking the level of the two implant. On the number 32 area, you can see the implant surface through the thin layer of the buccal bone. That's why we need the bone graft procedure. Reverse torque. Probably implant was placed too deep. Looks like reverse torque. Maybe Dr. Lee is thinking implant was placed too deep. Checking also the lingual side. No exposure of any of the implant surface. Probably he's now measuring the edentulous area to cover. He has trimmed the membrane. It looks good so far. So checking the level of the implant. As I mentioned, it would be better to placing two implants at the same level. But the risk of the exposure of implant surface should be minimized. Irrigation of cell line. So two implants were placed beautifully. Placing specially designed healing abutment. I'm going to explain more later about the advantage of this so-called transient healing abutment. The diameter of the upper part of this healing abutment is smaller than implant diameter. There is several advantages of this healing abutment. Looks very different from the conventional healing abutment, with decreasing the size of the upper part of the healing abutment. With this healing abutment, probably he's considering the vertical augmentation too. Then we can apply the bone graft up to the top of this healing abutment, and minimizing the size, the healing abutment, then we can apply more bone graft on that side, which means we can expect more new bone formation. let's say that there is a large diameter of the healing abutment. We cannot apply too much of the bone graft because of the size of the healing abutment. With this healing abutment, we can apply more bone and expecting more new bone formation. Also, sometimes we can use this healing abutment for stabilizing the membrane for the graft procedure. So there are several advantages of this healing abutment. So now, finally, we're gonna apply the bone graft. Osteon xenograft is going to be used, which is genogenic bone graft, bovine bone, similar to the human bone. Usually, the larger particle size is recommended for this kind of augmentation procedure. And also, I've heard osteon collagen graft also going to be used for the grafting procedure, which is synthetic collagenated bone graft, which is some advantage, very good indication for the extraction socket, and also good for the maintaining space on the minimizing the particle dissipation. So two graft material is going to be used for this procedure, and also membrane, collagen membrane is going to be used to cover the grafted bone. As I mentioned, for this case, unfortunately, we cannot use the titanium mesh or the non-resorbable membrane. After the surgery, the patient is going to move out of the country. Maybe he's preparing the graft material and the membrane. Yeah, measuring size of the collagen membrane too. It's good for the easy to operate and strong enough, it's preventing the tearing. It's high tear force. Evaluating the size of the membrane, and he's preparing the bone graft material. It takes a little bit of time. Osteon 3 and osteon xenograft, as I mentioned. Yeah, he applied the membrane first and osteon 3 collagen on the defect. This is osteon 3 collagen graft. As I mentioned, easy to mold, easy to carry, easy to manipulation. And also it's going to use the particle bone graft, osteon xenograft, which is porcine 아니죠. bovine graft material. Applying the particulated bone graft. It looks like he's doing some kind of vertical augmentation too. As I mentioned, with this transient healing abutment, we can we can augment the bone up to the level of the top level of the healing abutment. As minimizing the size of the healing abutment, we can apply more bone graft and expecting more bone formation. applying bone graft carefully. As I mentioned, for the augmentation like this, the particle size, larger particle size would be recommended. Minimizing the collapse of the augmented area, so we have to have some large particle size. So over build-up sometimes recommended because we naturally after the healing procedure there's going to be some shrinkage of the augmented area. On the literature it says up to 30%, 20 to 30% of the shrinkage of augmented area is going to be expected. Therefore, we recommend you to over build up. Grafting more than expected is recommended. Checking, he already, I didn't mention he already placed one pin on one side and is going to place another pin on the other side. That's why it takes some time for preparing. Some kind of bone tech using the mallet. Then using the GBR pin for the stabilizing the membrane. I think 2 or 3 pin would be enough for stabilizing the collagen membrane. And probably has to trim the membrane. It could be trimmed on the intraorally or out of the patient mouth. He chose the trimming the intraorally the membrane after stabilizing the membrane first, then trimming later. It's one way we remove the GBR tool from the GBR pin. He used the oval knife, so we can make sure the stabilize of the membrane with the GBR pin. We can apply another pin on the middle, or we can, I think 2 pin would be enough for this case. One of the most important things for bone graft is wound stabilization. So augmented bone and membrane should not be moved in. Otherwise, we cannot get enough bone for that side. Trimming the membrane on intraorally. The pinset on cotton plier on one hand and scissor on the other hand, covering thoroughly the defect and proximal defect, and also medial side of the number 33 and 43 tooth area. For this specific case, we don't have to we don't have to think too much about the regeneration on the medial side of the number 33 and 43, because as always saw, there's pretty much of the bone peak of the pressed-in bone, so we don't have to consider too much about that side. We can concentrate on the edentulous area and the buccal side of the implant, checking whether the membrane cover enough the defect and all the grafted area. The transient, the healing abutment could also be used the 10th floor. For the vertical augmentation, usually we have to place the 10th floor to minimize the collapse of the grafted area. However, this transient healing abutment, we can use it as a 10th floor, minimizing the collapse for the grafted area. applying another layer, probably the size of the defect. He applied a lot of graft material, therefore the one layer of the membrane was not enough. So covering another layer on the top of the graft area. Sometimes we can use the 2-layer or sometimes 3 layers when the graft, when the defect is larger than we expected. As I mentioned, the transient healing abutment is being used for the tent pole, as a tent pole for space maintenance, space maintaining. And suture, several different suture techniques. One of the most important thing is, as I mentioned, we have to make the primary intention closer. For that purpose, it will be good for, I think it's modified matrix suture. Modified horizontal matrix suture. End of the flap will be everted. So there's 2 surfaces, ringer side and the buccal side of the flap will meet. Therefore, we can guarantee more chance of the primary intention closure healing. So matrix suture was used as a first suture technique. And what will be the next suture technique? Usually for the particular augmentation procedure, I don't use the interactive suture. He's doing the another horizontal matrix suture technique for the primary intention, wound healing, primary closure. Yeah. Another suture, number 33 area. Because we already made sure that it is tension-free flap, because he made a releasing incision, buccal and linger side. We can expect the primary intention, primary healing. And the additional suture, probably we can use the interpretive suture for this case. No, he's using another modified matrix suture. Something like X suture or X figure suture. If you see from the occlusal view, it looks like X figure. Yeah. Anyway, it's good for the primary closure. So interrupted suture is not recommended for the augmented procedure because it's pushing down the flap margin. As I mentioned, the end of the flap should be everted, and the two surfaces of the buccal side and lingual side should meet, then it can guarantee more chance of the primary intention, as minimizing the chance of the particle membrane membrane exposure or the bone graft exposure. Do it again. So making the two vertical incision is one of the methods for the enhancement of the flap, but it was not enough. Therefore, he made the two releasing incision on buccal side and the lingual side. So making the vertical incision is also one of the methods for the advancement of flap. Interrupted suture for the vertical incision area. So placing two implants and doing some vertical augmentation was beautifully performed with the collagen membrane and transient healing abutment. Even though there is some shrinkage of the graft material during the healing, there will be pretty much of the bone, so minimizing the risk of the exposure in implant surface. I think the live surgery was beautifully done. So we'll have some break. Do we have to have some break, or can we go to the Q&A immediately? Break. We're going to have some break. Thank you for your attention. Okay. We took the panoramic radiograph after the ridge augmentation. You can see the thin layer radiopack material on the top of the healing abutment area, which means we successfully augmented bone up to the level of the healing abutment, which means the vertical augmentation was performed for this case. And we, as always saw, that we made the primary intention of the flap, then we can expect pretty much of the newly made bone. Even if there is some shrinkage of the loss of the bone on the top of the healing abutment, there would be enough bone to minimize the risk of the exposure of the implant surface on the buccal side. So this is the case we reviewed today as a live surgery by Dr. Seung-Gun Lee. It was beautifully performed. So one question is flap management on the lower anterior edentulous area for like this today's case. The important four principles for the augmentation. Primary closure, we already saw. He did a lot of effort. He made a lot of effort to make the primary closure using the releasing incision and the advancement of flap. He made the primary closure and also suture technique. He made successfully the primary closure. And another one, next one is angiogenesis. So preventing the unnecessary manipulation of the flap or something. So we have to make sure if there is enough angiogenesis. And for space maintenance, we use the healing abutment and we use the large particle size, the bone graft material, and the collagenated bone graft, and also membrane, collagen membrane. And for stability of the augmented area, he used the GBR pin, membrane pin. For sometimes we can use the suture technique for stabilizing the augmented area. This is a four principle, past principle, which was published in 2006, Implant Dentistry. This is one case in our school. It's not my case. One faculty's case is a ringer side flap advancement. As I mentioned, we don't usually use the sharper instrument on the ringer side. I'm going to explain why. And the buccal side flap advancement, we use the releasing incision with sharp number 15C blade, and made sure the enough flap coverage of the augmented area for supporting for preventing the collapse of the augmented area. So membrane pin, tent pole could be used for, but Dr. Lee's cases, he used the implant and healing abutment as a tent pole for maintaining the space, and also used the GBR pin for the stabilizing the membrane and the augmented area. And after the healing, you can see the right lower side, you can see we made enough pretty much of the bone for placing implant. This is the not simultaneous implant placement. It's delayed healing. After making the bone first, then placing implant. So in some severe cases, more severe cases, we can consider the two-stage approach like this. And placing implant. For the buccal side flap advancement with the releasing incision, making the two particular incision would be helpful for the advancing flap, but it's not enough for covering all the defect sides. Then we have to consider the flap advancement with releasing incision. And after releasing incision, we can use the needle holder or hemostat to widening the area to we can make the more flap advancement after releasing incision. Releasing incision first, and more flap advancement with the instrument like this. And also some cutback incision like this could be helpful for buccal side flap advancement. As I mentioned, 3 different techniques for buccal side flap advancement. And we have to be very careful. The lower side clinical picture shows where the mental foramen and the mental nerve is going from. Therefore, sometimes in the middle clinical photo, the mental foramen is located about, area of the second premolar area. But if you see the left-hand side lower, there's a mental nerve is very close to the canine area. So when we make some vertical incision on the distal of the canine area, we have to make sure in advance where the mental nerve is located. I think Dr. Lee already checked the location of the mental nerve and made the flat design like that. But some patient, the mental nerve is very close to the canine area, so we have to be careful. So mental nerve go from the mental foramen and go like this, the large area on the cheek and the gum. So we have to be careful preventing the numbness with cutting the mental nerve innervated area. So also the mental artery and mental nerve should not be cut during the flap advancement procedure. Lingual side flap advancement like this in the middle clinical photo, we can make pretty much of the advance of the lingual flap. There is some important artery going to under the tongue, but we manipulate usually. Can you see the indicator? Manipulate this area, so we don't have to worry too much about cutting the sublingual artery and submental artery. Once you cut this area, it's very life-threatening risk for if we cut it, we can stop the bleeding on that area. So we have to be very careful, not touching, not cutting the sublingual artery and submental artery. That's why I don't really like to use the blade on the ringer side. But if you pay attention, I think you can use the sharper instrument. But instead, my preference is the instrument like peristaltic elevator for advance of this area. So, as I mentioned, bleeding on mouth floor could be the life-threatening. So we have the best thing. We have to be careful, very careful, not cutting the artery on the procedure. Sometimes, usually not during the flap advancement procedure, when we are placing implant, we can place, the cortical perforation on the ringer side and the cutting the artery, sublingual or submental artery. It will be very dangerous. There's one report, life-threatening hemorrhage by partial and complete perforation of the ringer cortex. I think canine area, most of the cases happen to canine area and lateral incisor. Especially when we are doing the implant site preparation, we have to be careful not perforate the ringer cortical bone area. Then also we have to be careful for the flap advancement with the ringer side. So he made the cortical perforation on the buccal side. So for the upper maxillary area, there's controversial, I think, but the lower, the mandibular area is most of the bone. Component of most of bone is cortical bone. Then in that case, we have to consider cortical perforation to expose the cancellous bone under the cortical bone area. This is my preference. I'm using number 2 round bar to make the cortical perforation. So this one report is the influence of the cortical bone perforation on GBR in humans. Cortical bone perforation favorably affect the amount of new bone formation, and the cortical perforation significantly increase the number of new bases, which means more chance of making the new bone. Therefore, that's why I recommend the cortical perforation. Another paper which was published in 1999, left-hand side, they didn't do anything. The right-hand side, they made on the test group, they made, the cortical preparation, the result is if you see the right-hand side, you can find some fusion between the layer of the lamellar bone and the open bone, which means the newly made bone and the pristine bone, there was some fusion. So more better quality of the bone for placing implant. But however, on the left-hand side, there is some, it's not favorable healing status could be seen in the control group. Therefore, I think my recommendation is it will be better to do the cortical preparation on the lower anterior area. So this is the result. After 16 weeks, there's more new bone formation and blood vessel on the study group. And he used the transient healing abutment. I've never used it before, but I think it's a very good idea. So conventional healing abutment in the left-hand side is large diameter, sometimes for the posterior tooth area, diameter is 5.5. But transient healing abutment, as I mentioned, the diameter of the healing abutment is smaller than implant fixture. The one advantage of transient healing abutment is very good for primary intention wound healing. As you see on the left-hand side, and once you connect the healing abutment, it's very difficult to make the primary intention. So therefore, there will be secondary intention wound healing. And eventually, there will be some bonus between implant, researcher said. And the right-hand side, if you use the primary transient healing abutment, there's more chance of primary intention wound healing and also can minimize the bone loss between two implants. And also another advantage of this transient healing abutment is very convenient for bone graft procedure, as you saw from the live surgery. Because of the small diameter of the healing abutment, we can apply the more bone graft on that area. And sometimes it's very good for stabilizing the membrane. You can make some punch and this hole, then the hook on the healing abutment. That is very helpful for stabilizing the membrane. Also, we can apply more bone graft on that area. And also, if you see the left-hand side, let's say we connected the large diameter of the bone healing abutment on that area, then we have to apply less bone graft on that area. But in this case, because we connected the transient healing abutment, we can apply more bone graft, and there will be more chance of new bone formation later. So advantage. Second advantage is convenient for bone graft procedure. So also it's convenient for soft tissue graft procedure. Once, as I mentioned, not even for the bone graft procedure, for the soft tissue graft procedure, we can apply the soft tissue graft on the top of the DC healing abutment. It's a third advantage of transient healing abutment. And for the last one, so I'm going to explain more about bone graft and membrane we used. Collagen membrane too was used for the live surgery. It's guaranteed the faster wedding and easier manipulation. And this is resorbable membrane, so we don't have to have additional surgery for removal of the membrane, and the long-term stability, which means it can stay there for the space maintaining after the grafting procedure, and the guarantee is the more space maintenance in that area is minimizing the soft tissue ingrowth that area to maximize the amount of newly made bone on that area. It's multi-layered microstructure. And the osteogenegraft is a bovine bone graft material which has a similar structure. If you see the right-hand side lower, it's very similar to the human bone, and very good, easy to manipulate, and as I mentioned, the particle size is good for augmentation. And the osteoarthritic collagen is originally is designed for the rich preservation procedure for the after tooth extraction, and it is also good for the rich augmentation because it has a space maintenance and easy molding and slow resorption and minimal particle dissipation. Is a good property for the grafting procedure. This is also collagen 3 graft, collagenated bone graft, and it's a collagen. The particle of the graft is connected each other with the collagen constant. So it's originally designed for the rich preservation procedure and also good for the bone graft procedure, as I showed you. So this is all about it. Thank you for your attention.